So, esteemed colleagues, now we're coming to the discussion part, and I'd like to ask our experts to come to the stage. From therapists, I can see some changes. Karina Leonidovna, there is no Andrei Yurich, maybe Vladimir. You, Ludmila. So who can come up to the panel? And of course, I would like to see here at the stage.
And please have a seat on the same place.
And of course, Sergey here is in our list. And Michael Sergeyevich, please come to the stage. So who else? There is no Elena. She's not in here. Eugene will come.
You are our experts, and we would like to listen to your opinion regarding our conference. Меня не надо тогда, я буду из зала, потому что я...
Виктор Анатольевич, можно пока рассаживаться? Вопрос по поводу больного для Сергея Леонидовича.
Ага, конечно.
Вы не дали его задать?
Да, у меня... А то вас там не видно совсем.
Нет, нормально, оставьте нам. Сергей Леонидович, был вопрос, да, вы так похвалили.
Sergey, you were so happy about those biopsy pieces. For to diagnose carcinoma, it's enough for you. But we talked about PSC. Since periductal fibrosis, would this biopsy be informative to verify PSC? Would it be enough to have such a small piece? It's an interesting question, actually. That was a proper comment from Alexander. Is that the more material pathologists have, the better. That's the right way to say. But we can't have more material with that endoscopy. That's why if you have 2 millimeters and several biopsies of that size, then in this case, I see we consider the sufficient material, amount of material. Talking about the specific disease, then if the material is taken not from the surface but with the submucosa, where could be the signs helping to verify this process, it could be enough, maybe not, but at least submucosa, looking at submucosa, we could verify those processes as well. Maybe Vadim, you want to comment on that? On the to participate in this morphological discussion. Well, I would be not that bold in this situation because seeing this clinical endoscopical pattern, what I can think of, what I would see, of course, I would see signs of chronic inflammatory process with this color of bile. It's something wrong with that. So there should be some inflammation there. There should be some reactive, proliferative changes in epithelium. But to say for surely with regard to nosology, well, I think it's hard for me to say right now. But for that, of course, we need to see FNA from liver margin. Yes, with this, I would like to focus on that final talk, on the final phrase. I wanted to ask this question during the demonstration, during surgery, because we discussed a lot which type of the extrahepatic lesion we have. Is it like PSC or not? But less invasive and more available and even less costly. It would be to do good quality liver biopsy to involve us, morphologists at least, prior to all those testing, and maybe we could diagnose the disease just by starting the liver biopsy piece. And that's why doing those, and with all those manipulations, we will think about other issues. We'll think about if it is how far is involvement of the disorders, what is the compression, and so forth. But we would know that there is a PSC or not, or we would search for adenocarcinoma because it could be associated, or it could complicate the PSA development. As to our experience, FNA is not that informative for PSC. We thought about 13% of informative value because PSH is a mosaic process. And with the last patient, you saw everything which we discussed today. When we have to do RCP and about those advantages of RCP versus MRI, and how many of the diseases we have to treat. How many of diseases result in strictures. So the last patient actually was a demonstration of everything, of all the issues we discussed during the whole day.
Comments regarding this topic, or maybe you would like to open any new topic for discussion?
Yeah. Well, I want to thank you a lot. It's a fantastic teaching course today. I'm sorry I missed yesterday. So in all these malignant diseases of the hepatobiliary tract, your discipline, the surgeon, remains the gold standard. This will be even in 100 years, let's say, or even beyond 100 years. And in addition, with the chemotherapy, I only mentioned a few words, and we learned from the pathologist and from the oncologist how to differentiate the malignant processes in the whole area. And the radiotherapy will always only assist, not cure, assist. It's a matter of debate that some patients or some doctors think that with modern radiotherapy approaches you may solve the problems forever. But as you know, or we all know, this will not be the case. Even if we have fantastic progress last 5 years with all the modern techniques, we call it somehow, for example, involved radiotherapy, in intensity modulated radiotherapy, where we get a much higher doses than 5 years before. So the rule of local control remains to be clarified in interdisciplinary studies. It makes no sense that only the Society of Radiation Oncologists or radiosurgeon with CyberKnife discuss how to optimize the treatment setting in patients. It's a matter of combined studies. It was mentioned with a neoadjuvant setting, with a primary setting in a combination of radio chemotherapy. So this whole field remains one of the few fields in whole oncology where the evidence is so small for our patients. So in our center, the value of radiotherapy in these diseases remains very, very small. Only selected cases, after a roundtable discussion with the doctors, then we drew the conclusion for our patients to do the radiotherapy. We do it more routinely post-operative, and as I mentioned in the CyberKnife, for selected cases, only selected cases where it cannot be operated. The first choice is the operation, the second choice is the radiosurgery, and the cases are so selected, so we need to have one metastasis or 3 beyond smaller than 4 centimeter, and there are so many other techniques available as well to ablate quite safe metastasis. So I'm quite optimistic that in a few years outcome will be better, but still there's a lot of work to do.
Thank you very much. And Dr. Deschamps, thank you for your operation. And we start to discussion regarding the delineation between inflammatory and tumor disease, and the second topic, the place of the ablation and radiotherapy in the multidisciplinary treatment of the cancer of this area. And please make any comments regarding these topics, or maybe open another one.
No, I mean, this is a very interesting topic in itself. And you touched upon the differentiation between inflammatory changes and malignant changes, and this is one of the most striking challenges we have today in the management of people with chronic inflammatory biliary disease. But I mean, it's the same in chronic inflammatory bowel disease, for example. Chronic inflammation will be the promoter of dysplasia, which will ultimately end up in malignancy. And especially when we look at patients with a chronic inflammatory biliary disease like PSC, I see that we constantly struggle to correctly identify the region where there's which progresses furthest into the direction of malignancy. And what we do today is we look for strictures that look malignant and take biopsies there. And of course, we only use the morphologic changes which cancer will bring in the liver to find it, which means we are always too late, because we only identify cancer the moment it's there. And by today, we don't have the tools to say, okay, this patient is at risk and this region is at risk, and maybe, for example, resection of a part of this liver lobe now will spare him or her tumor in a few years. And there have been many groups who address this. Some just examine the contents of bile, proteomic diagnosis for special combination of proteins, and they say, okay, if the combination of proteins is like that, you will have a much higher risk of cancer, or cancer is even there. But still, this is the result of a single group, and it has not been confirmed otherwise, so you can't really believe it. And then there are others who use endomicroscopy to look at cells in the biliary tract to pick out single cells and look at them and say, okay, we've got this and this problem. And then you can find cancer when it's there, but you can never screen the whole liver or the whole biliary tree. So this is a problem we have for a long time, and we have today. And although there are first ways of addressing this, we will be stuck with this problem for much longer, I think.
From my point of view, I would like to comment on that. In our cancer center, we do a lot of hepatectomies, and that's what Alex mentioned, that it's very important for us to see the upper and lower margin of this tumor, so to do some radical surgery. But it's impossible, because the tumor, it is of a different biology. It not only is located in epithelium, where we can see it by eyes, but also it grows through submucosa. That's a question to a morphologist. So if you agree with me or not, or maybe you have some experience, that after surgeon tells you that after doing radical hemihepatectomy, that you see that non-radical margin, the tumor is not radical margin, in how deep the tumor goes in liver, in submucosa. What's about your experience? How could you assess is the surgery, how you felt, was the surgery radical or not? Well, with regard to oncology, I tried to tell to the audience that intraoperational studies with regard to diagnosis, it's not that good thing. The thing to do the CITO, the emergent studies to find the resection margin. It is an urgent procedure. We have to do it, and it's very complicated. So when we talk about so-called sanitary tumors, these tumors are usually, they have some margins, and in cases when we talk about, let's say, in this case we should understand that we either talking about the tumor, which is solid in its structure, which is focal, and there is not that many problems. There are no problems either with surgery or with morphological assessment. When we talk about the ductal carcinoma, when it's very hard to assess it visually how far the tumor is spread, it means that for morphologists morphologists is stuck with a very serious problem, and not often we can clearly say if the resection margin is appropriate or not. That's why our urgent report is of so to say presumptive type, and not the very rare it's a clear cut. If there is no tumor, we could be sure, but if we see something which is similar or which seems to be a tumor, then we cannot give the final answer in most of the cases, and that's a big issue with morphological diagnosis. There is one more thing which I'd like to draw your attention to. The thing is that in specialized labs, we can do urgent studies simultaneously. I mean, urgent cytology and urgent histology, because we don't have much of the material. That's why emergent. So for emergent diagnosis, even the cell composition in cytology and in histology may be of a value for us to diagnose it in in urgent settings. That's why the combined use of material cytology and histology improves the general performance of our diagnostic routine. And I'd like to, if I may, I'd like to mention two important issues. As it's a probability and chances for intraorganic tumor metastasizing even with such a growth type, because it's possible, and it makes it possible for us. It makes it possible for us to give you a clear answer. On the other hand, it will depend on the localization of the mass of the tumor, and we know that it might spread in all possible directions. So I think we have more of questions than answers in this respect. And I think we should say the following. When we talk about the invasive adenocarcinomas, which are already there is no problem with differential diagnosis, including in the resection margins. We're talking about the problems, or I would like to bring the idea here that quite often we talk about the intraepithelial neoplasias, non-invasive carcinomas, for instance, when it's very hard for us to diagnose them, not only with urgent, but even with, so to say, planned or elective examinations. That's why those early non-invasive cancers, those borderline cancers or low-invasive cancers, they are the main complex feature for us in diagnostic sense. Then, Alex, I have a question for you. How can we optimize, or how to optimize this information which we obtained with all those methods to assess the margins in case of cholangiocarcinoma, the tumor margins in case of cholangiocarcinoma? How to use all this information in optimal way?
The optimal way is to get as much information as possible, which would be let's go away from a chronically inflammatory biliary system to a patient with a cholangiocarcinoma. The optimum would be, of course, to secure the diagnosis by having a proper tissue sample, and then to find the margins of the tumor. We have tools to find the margins inside the biliary ducts, which is cholangiography, as you've seen, which is cholangioscopy, which can give you an idea of the changes in the ducts. Today we've got cholangioscopy probes with a diameter of 1 millimeter, which you can stick in each and every side branch to see, is there tumor or do I see tumor here? And of course you can combine this with EOS examinations, which will focus not on the luminal side but on the tissue outside of the ducts. But still, in my experience, you create a lot of evidence for a model you have in your hand at the end, and then I take this model to the surgeon and say, look, this is what I think. We've got a carcinoma of that type, extending here and there. And more often than not, after the operation, the surgeon and the pathologist tell me, you had a good guess, but I found it to be different. Yeah, there was more tumor there than you said, or sometimes they even say, no, it didn't extend in this branch. This was just inflammatory disease. And the key method, the one key method which will tell us everything, is missing. And I'm not sure if we will ever be much further in this regard.
I have a question, please. In ESMO recommendation and in CN guidelines, we have quite interesting idea that if we have radiological evidence of the malignant disease in this area, we could use a surgery up front, and only then we have to receive the biopsy. To what extent is this true? Where is the cutoff point? What extent of surgery is appropriate in this case? Where we have to perform the biopsy first, and when we have to do surgery first? What is your opinion about this?
When you ask me, you ask a non-surgeon. Yeah. So yeah, this is from my standpoint. Surgery is something which I try to spare to the patient. You can throw stones at me for that, but in my opinion, always endoscopy is gentle, surgery is brutal. This is wrong, I know, but this is the standpoint. And then I try to do everything which is possible before opening the abdomen of a patient. And now, please ask a surgeon. He will have the complete different opinion, because he will say, and with some correctness in that early surgery can save lives, whereas dancing around the biliary tract with endoscopy can sometimes be so prolonged that a patient will not have any benefit, but will have his operation postponed beyond the point where it would have been curative. So that's a matter of debate, really.
Yeah, I think it's different from. I think it's different when you consider what we have seen today. So it's PSC is a completely different story than a patient who presented with jaundice and cholangiocarcinoma. Because I think distally, I think the problem is to separate the distal and the hilum, because the hilum is very complicated. Distally, sometimes you don't even need a diagnosis. You can, we can talk about this, but you can, for example, I think one problem for me is when they put a stent, the brush comes back negative, and then I cannot see anymore I have to imagine the wall thickening in the middle of the stent. So I think, what I think is that when you have a patient that, for example, has jaundice, you have to decide before. So if you want to send directly to surgery, you can do it. If you want a diagnosis, I don't think nowadays you should do a ERCP first, but you should do a US, getting the diagnosis, and then decide also if the patient needs drainage or not, because it's not really, unless he has to wait, it doesn't change the operation. And the hilum, I think, is a very complicated issue. So I think the Japanese, for example, they use percutaneous cholangioscopy to see where, and there's no, I think there's no perfection, and 25% of the patients with hilar lesion goes to surgery, and then they have a benign disease. But I think it's different to talk about a patient who is 60 years old that has jaundice. So the first things you think is cholangiocarcinoma, then a patient who's young, who has a PSC, who has a PSC kind of everywhere. So the cancer can be extrahepatic, intrahepatic. So you cannot really prevent cancer, other than taking out the liver and giving a new liver. So I think it's a different story. And I'm happy about the new radiological, the development because they give us job, because we put fiducial, because in order to do image guided, to do cyberknife and all this stuff, they need to point the radiation. So we started also to place fiducial, and I think this is the future, to try to spare patient from more invasive, to spare patient from the surgeons. That the surgeons are very important, but at the end, if you are able to be less invasive, it's better for the patient.
Let me comment on that. You're totally right with the fiducials. We need them because the X-ray tube of the cyberknife is not recognizing soft tissue contrast like a CT because it's conventional X-ray. That's why we need these gold markers. And we need them for the intrahepatic lesions. And we prefer in Hamburg area the lesions where the surgeons does not like to operate. So the first choice in our tumor board is the surgeon. And then if they go more centrally to the veins, then it's the job of the radiosurgeon. So this is our new field of radiotherapy. And we term it not cyberknife because we have alternative technologies nowadays to focus on a lesion in the liver to get a local control rate for 2 years of 90% maybe. You can do it with a LINAC as well, as you know, and then it's called stereotactic radiotherapy. This is we have enough evidence for these techniques now, and they are very sufficient. It's more a matter what we just discussed previously with the margins, for example, in the classic whole angiocellular carcinoma. That is what I mentioned just before. This will never be a method of the cyberknife because we have the same, besides the normal tissue, of course, the mucosa, which is very sensitive for radiation, as you know. We cannot deliver the high dose, the high biologic dose of at least 100 Gray to cure the local disease because we don't know the margins, even if we perfect contrast enhance PET CTs, MRI, CT, and the PET CT, and even with whole data fusion sets, it's not possible to know exact what is going on in these complicated cancers.
So one aspect of what you said struck me because you were referring to the tumor board again, and this is something which I think is very important again when you are asking which patient to send where. The question should be different. That the doctors have to be sent to the patient to sit together and discuss it, and only in interdisciplinary discussion. And we've said this a number of times, but it's important. So I just repeat it: the interdisciplinary discussion, along with all the morphologic evidence we have, will bring a plan which everyone will stick to. So everyone has his say, and in the end, we will get a consent about what to do to this patient, and the surgeon will have his say, and the endoscopist and whoever. And in the end, the patient will be offered the best choice we have for him in this moment. And this, I think, is the best thing we can offer, that we get to the conclusion together and offer him. And sometimes you have to tell a patient, look, there's 2 ways to do it, and this could mean that, and this could mean that. And now, please, you have your say in this, yeah, and you decide with us together. And we've got tumor boards without patients, and we even got tumor boards with patients. And I feel that this is, for the time being, as long as no one really knows the absolute truth, this is the way to do it.
I agree.
Thanks.
Какие-либо еще?
Any more unresolved issues? Well, we had lots of ideas to open up discussion during the lecture, during the translation of the surgeries, maybe in the audience. We have specialists who would like to ask questions to our experts, who would like to have more detailed answers. So please do not feel shy. You have a unique opportunity. We have experts, world-class experts here, so please do not feel shy. Please use this opportunity. Maybe you have something left still unanswered. we used these opportunities during the translation to ask us questions during the interventions. So if there are no more questions, I think we have to summarize the situation. We had 2 great days, and the main idea, I'd like to remind you about it, is that the main idea of the conference was to look at the problems of diagnostic and treatment of pancreatic biliary diseases from the different points of view, from the point of view of therapist, gastroenterologist, morphologist, endoscopist, and the surgeon. And it seems to me that the main, so to say, outcome of this conference is that in this room we actually managed to accumulate international interdisciplinary team, which demonstrated truly the prevalence of interdisciplinary outcome. And these were so complex cases. It was not a record. It was a real-time translation. It was real patients. It was a real 2-day, so to say, section of the work of the clinic with such a strengthened interdisciplinary team. And I think that you really practically could see how we should work with patients. And at the end of the day, I would like to thank, first of all, our foreign guests who actually interrupted their, so to say, working practice. I would like to thank Dr. Largi, Dr. Deshan, Dr. Filauer. Thank you. Thanks a lot for you staying with us, because you can't imagine how busy those people are, how tight is their schedule, but still they managed to find time, they managed to come to our country in that very complex, so to say, day. And they really gave us a strong momentum, and they moved our educational workshop to an absolutely new methodological, so to say, level, because it's very high. Also, I would like to thank all our experts who participated in this conference, who talked to us, who participated in this symposium. I would like specifically stress our multidisciplinary endoscopic unit, who were most loaded with this event. I would like to thank to our gastroenterology and oncology units. These are all elements of our interdisciplinary team who worked for you and for good of our patients those 2 days, and we tried to make our conference as interesting as possible and fruitful. And we tried to every minute of your precious time to use as much as possible. Maybe me overloaded, so that overburdened this conference, so to say. Maybe next time we'll try to do it not that intense, but we wanted to share this information in the most possible, so to say, we give most of the information. Also would like to thank the group of Svetlana Alexandrovna, the marketing group, who actually provided all the elements, all the sections, from mailing the invitations and with the internet page, and up to all this invisible activities, which actually made our conference comfortable and make it such a great success. And also would like to thank our great group providing the translation to us. Look at this great images, this Ibra company, and they are our permanent partners for our educational events. They provide solutions to all those situations. Lots of HD pictures, online translation to the internet, and we could translate for 2. We did translation on 2 large websites, and many doctors who couldn't come to our conference, they actually could watch it online at their locations. Also, I'd like to say I could tell a lot about those involved in the organization of this conference, but I'd like to express all my gratitude to everybody who worked at this conference, even if I haven't mentioned you, as we're short of time. And especially, I would like to stress this great job of our interpreters. That is that you can't imagine how much our work they did for simultaneous medical translations. You know the terminology they did. That's a great workload, and the requirements are very high. And simultaneous translation was absolutely excellent. Thanks a lot. And I would like to thank you, and I would like to remind you, dear colleagues, that in our clinic, on the basis of the State University, with the active involvement of the faculty, so-called faculty surgery department, we are going to set up similar educational workshops, and our main trend is to set up conferences with participation of our European and Asian partners. Ideally, we'd like to enter the international level. Ideally, we'd like to make English the main language of our conference. Regretfully, it's not possible. We do combinations to make things more comfortable to the audience, but we would like to tell us that let's catch up, because without integration to the world medicine, to the global guidelines, to the global educational events and associations, it's you cannot move forward, so to say, being alone. So we shouldn't create any borders, or so to say, outside us. We should try to integrate into all international movements and organizations, and we should actively cooperate with all of our colleagues doing that great job to us, coming to us and sharing their knowledge and skills with us. I also would like to once again to thank all our sponsors, and first of all Olympus, who is a general sponsor of all our educational events, and which makes possible to make these events a real thing. I would like to remind you that in April we'll plan the stomach surgery school. That's a third school which will be based on inviting our Japanese surgeons and morphologists who are who are the leaders in this field. But of course we will ask and invite our Western partners, because from our point of view, we should work together despite any borders. We should work on the transnational levels, and everything, all the best from Asia and America and Europe, should be acquired and used, and that's the only way to move forward. Now I'd like to wrap up and close the conference. Thank you for the attention. Thanks a lot, and see you next time. Thank you.